So, what's meant by portal hypertension? Portal hypertension is elevation of the pressure within the portal venous system. Okay, as you know, we have two circulation. We have what's known as portal circulation, and we have what's known as systemic circulation. The portal circulation is formed from superior mesenteric vein combine and union with splenic vein to form portal vein. Inferior mesenteric vein itself will join them either through drainage into splenic vein directly or drainage into the confluence. Okay, all of this will form a portal vein. The portal vein will divide into right and left branches, and then it will give the blood to the sinusoids, which act as the capillary bed. Right? Okay, so the blood direction is from the intestine and spleen toward the liver, right? And then the liver, the sinusoids, which act as a capillary bed, exchanging gas and the nutrients, and all of this waste will go to the central veins, back to the three hepatic veins, and back to the right atrium again, right? So this is called the portal circulation. This portal circulation, the pressure inside portal vein should be always less than pressure inside the right atrium by 1 to 5 millimeter mercury. Okay, they should always be less than the pressure inside the hepatic venous system, which is considered as a part of systemic circulation. But when the pressure elevate inside the portal vein, this is what known as portal hypertension. And this is a big problem, and we will know why. But first of all, what may lead to increased pressure inside the portal vein? We have three causes. We have a pre-hepatic cause before entering the liver, like in case of if you have a portal vein thrombus. Just imagine if I have thrombus here inside the portal vein before it enters the liver, the pressure will start to build up inside the portal venous system and it cannot pass due to being occluded by the thrombus. So the pressure inside the portal venous system will elevate. This will cause portal hypertension. And in this scenario, the cause is pre-hepatic, before reaching liver. And the cause here was portal vein thrombus. So we call this as a pre-hepatic cause. But what if I told you we have another scenario? And by the way, this is the most common scenario, you should know it, which is the hepatic cause. What if we have cirrhosis? And I guess all of you is familiar with this term. What's meant by hepatic cirrhosis? Hepatic cirrhosis is the common endpoint to all chronic disease of the liver. Any chronic disease in liver, its end stage is called cirrhosis. It represents the hepatocellular necrosis being complicated by three items: fibrosis, nodular regeneration, and loss of hepatic architecture. And by the way, cirrhosis is completely different from fibrosis. Okay, fibrosis, we still have preserved hepatic architecture, but in cirrhosis, we lost the hepatic architecture. So again, if we have a cirrhosis, and what's meant by cirrhosis? Cirrhosis is the endpoint for all chronic liver disease. Okay, whether it's due to alcoholic hepatitis, autoimmune hepatitis, viral hepatitis, metabolic storage disease, steatosis, in the stage of steatosis known as MASH. Okay, all of this, if if left untreated, this will lead to liver cirrhosis. Okay, and what is cirrhosis? Hepatocellular necrosis being complicated by fibrosis. Yes, it's component of cirrhosis, and also nodular regeneration, but it's a characteristic point from fibrosis that we have loss to the normal hepatic architecture. Okay, the nodules will regenerate, but in an haphazard form, in a random form, leading to disruption of the normal hepatic architecture. And what is the problem with loss of the normal hepatic architecture? This will lead to increase the pressure inside the sinusoids. This will lead to impaired the nutrient and gas exchanges within the capillary bed or within the sinusoid bed. So cirrhosis will lead to distortion of the hepatic architecture, will lead to increased pressure inside the sinusoids. And of course, if we have increased pressure inside the sinusoids, when the portal vein try to bring blood from intestine into the liver, it cannot enter into the sinusoids due to markedly elevated pressure inside it due to cirrhosis. So cirrhosis elevates the pressure inside the sinusoids, and the portal vein cannot push the blood in its system into the sinusoids due to marked elevated pressure. This will lead to build up of the pressure inside the portal system, causing portal hypertension. And this is the most common cause. And in this case here, the cause of portal hypertension is a hepatic cause, is due to cirrhosis, is due to a loss of normal architecture leading to elevating pressure inside sinusoids that reflect back on the portal venous system, causing elevation of pressure inside the portal venous system, causing what's known as portal hypertension. Okay. The last scenario, you may have a post-hepatic cause. You may have a normal portal vein with no thrombus. You may have normal liver, but just think, if one of the hepatic veins or the inferior vena cava itself is occluded, what will happen? The hepatic lobule will try to push the blood into the central vein, which is the hepatic vein, but it's occluded. So what will happen? This will lead to increased pressure inside sinusoids, and this increased pressure inside sinusoids will reflect back on the portal vein, causing elevated pressure inside the portal vein, also leading to portal hypertension. And the cause here is due to post-hepatic cause, which is called as venous outflow obstruction. Okay, so regarding the causes of portal hypertension, it may be prehepatic like thrombus, it may be hepatic, it may be post-hepatic as venous outflow obstruction or obstruction at level of hepatic veins or IVC. Okay, so the pressure is elevated. And what is the problem with the elevated pressure? But first, I just need you to know this clinically. Do you know how we measure the portal venous pressure? We measure it using a catheter that introduced through transjugular vein, and it will entering through the IVC and then the hepatic veins. And we measure what's known as free hepatic venous pressure, and then we introduce a balloon occluding the vein and proceed our catheter into the smallest branch of the hepatic vein to measure what's known as wedge hepatic venous pressure, and we subtract wedge hepatic venous pressure from the free hepatic venous pressure to measure indirectly what's known as hepatic venous pressure gradient. It should always between 1 to 5 millimeter mercury. Okay, I know you do not need to know this. This is regarding the gastroenterologist. They are familiar with these terms, and for you as a radiologist or sonographer, do not bother yourself. But I just need you to know how do they do so. It's an invasive procedure, as you can see. Okay, but it's the most accurate one. Just remember that the portal venous pressure normally should always be less than the systemic venous pressure. Once the portal venous pressure equal and start to exceed the central venous pressure, we will now develop the portal hypertension. And what is the problem with the portal hypertension? This will increase pressure inside the portal vein with creation and may lead to formation of varices and variceal bleeding, and of course ascites with liver cell failure as the case is progressed. Okay. Okay, so this is the normal liver, and this is what cirrhosis do. As you can see, what this cirrhosis do, we have a fibrosis, we have a nodular regeneration, but in an haphazard form, in a random form. Okay, causing loss of the normal hepatic architecture. This led to increasing pressure because this nodular regeneration will increase pressure on sinusoids and will compress sinusoids, causing elevation of sinusoidal pressures that will reflect back on portal vein, and no nutrient, and there is no proper nutrient or gas exchange takes place in sinusoids, and the liver start to fail. This is what's known as in the spectrum as a liver cell failure. Okay, why it failed? Because it cannot exchange nutrient and gases efficiently. Why? Because we have a nodular regeneration in a haphazard manner, compressing the sinusoids, impairing the diffusion process and impairing the exchange process. This is known as cirrhosis. Okay, and of course, many examples of cirrhosis. You may have cirrhosis just in early stage, in which the liver will be just coarse, inhomogeneous echo instead of being homogeneous one. It starts to be showing rounded or enlarged caudate loop or rounded capsule. Okay, and you may see it in advanced stage, like in this image, with irregular capsule due to fibrosis and regeneration and formation of ascites. And by the way, cirrhosis is a large spectrum. You may have an early cirrhosis that do not cause liver cell failure. So not every cirrhosis is a bad scenario because you may have a controlled cirrhosis. Patient may have cirrhosis, but he is controlled. The liver cells start still able to act normally, and he has a normal hepatic reservoir that can act as that can function well. Okay, but as this cirrhosis progress within years, it will lead to destruction of this hepatic reservoir till we reach liver cell failure. And what is the most important sign of liver cell failure is ascites and variceal bleeding. So varices itself, it's not indication of liver cell failure. Varices is an indication of increased portal pressure, which is known as portal hypertension due to liver cirrhosis, but it's not a sign of liver cell failure. But bleeding varices is more advanced stage of cirrhosis. Presence of ascites is an indicator that we are entering the liver cell failure stage, not only early cirrhosis. Okay, so if you have a portal hypertension due to any cause, either prehepatic or posthepatic or hepatic cause, what are you supposed to find on ultrasound? First of all, on B mode, increased portal venous diameter more than 13 millimeter. But remember, you should not measure it at the confluence outside the liver in the midline, and you should not measure it inside the liver because you are measuring here the right portal branch. But you should measure the portal vein at porta hepatis just outside the liver capsule. Okay, and also avoid to measure it during deep inspiration. This will overestimate the diameter size. Okay, so if you do this recommendation and this teaching point correctly, the portal vein should not exceed 13 millimeter. If it exceeds 13 millimeter, you will report this as dilated portal vein. Just dilated portal vein. Do not write portal hypertension depend on the size alone, because even increase of portal vein diameter more than 13 millimeter, this is not a sure sign of portal hypertension. If it's 14 millimeter or even 15 millimeter, this is not a sure sign. So how could you report this? You will just write dilated portal vein. It may represent early sign of portal hypertension, yes, of course, but we do not write definite portal hypertension depend on the diameter alone. So increase portal vein diameter more than 13 millimeter, yes, it's one of the finding, but it's not the only finding and that we depend on to diagnose portal hypertension. Also in color mode, if you open activating your color box on portal vein, it may show still hepatobetal flow and still we have portal hypertension. Okay, so can I diagnose patient with portal hypertension even if the portal still have red color or still have hepatobetal flow? Yes. So how can I reach this diagnosis? Because in this case, we depend on velocity. Velocity is the sure sign of portal hypertension, as we will see. So on color mode, the portal vein may still show hepatobetal flow. It may show hepatofugal flow and it may show bidirectional flow. And by the way, if it show hepatofugal flow, that the flow is going from outside the liver back to the portal vein, this is a sure sign of portal hypertension. So if you have a portal vein with normal diameter but show hepatofugal flow, yes, this is a definitive portal hypertension case. So the color mode, if it's hepatofugal, this is a sure sign for you to write it as a portal hypertension. If it show hepatobetal flow, we may be not, it may be portal hypertension or not, or normal. We will depend on the size, and the most important one, we will depend on velocity. Okay? But what if you have a bidirectional flow? What's mean by bidirectional flow on color mode? That the portal veins start to show two color alternating with each other, not in the same time, alternating with each other. Sometimes red and then reflecting back to blue. Red, blue. Red, not in the same time. I mean, it's red and then blue. Red and then blue. This is called bidirectional blood flow. And this is a query and suggestive of portal hypertension. We have two differential diagnoses for this condition. If you see two different color alternating after each other inside the portal vein, you are dealing with two differential diagnoses. One is portal hypertension, sign of portal hypertension. Two, it may be sign of cardiac congestion or hepatic congestion due to cardiac cause, like we will discuss later. Okay, so again, increase portal vein diameter more than 13 millimeter, suggestive of portal hypertension, but not sure. On color mode, the portal hypertension, the portal vein may show still hepatobetal flow, and it may show hepatofugal flow. But if it show hepatofugal flow, this is for sure 100% portal hypertension. If it show bidirectional flow, it may carry two possibilities, either portal hypertension or hepatic congestion due to cardiac cause, as we will discuss later. And I will tell you how to differentiate between both scenarios. Okay? Now, if we apply pulsed wave Doppler on the portal vein, the first early sign you will see in portal hypertension is loss of the respiratory physicity. Remember, the normal portal venous waveform, it should be monophasic, showing respiratory physicity. If we lost this respiratory physicity and we have a blunt monophasic waveform does not change with patient respiratory cycle, this is an early sign of portal hypertension. But remember, this is not a sure sign. It is suggestive of hypertension, of portal hypertension, in specific clinical scenarios, that we have a cirrhotic liver, we have a coarse liver with elevated abnormal liver laboratory finding. Okay, so loss of respiratory physicity is suggestive, but not sure sign. Also, the velocity will start to decrease less than 15 centimeter per second, and still from 10 to 15, this is suggestive of portal hypertension. But if the velocity become less than 10 centimeter per second, this is 100% sure of portal hypertension. So again, loss of respiratory physicity, suggestive, not definitive, suggestive of early changes due to portal hypertension. Velocity less than 15 centimeter per second from 10 to 15 is also suggestive of early changes of portal hypertension. But if velocity reach less than 10 centimeter per second, this is 100% sure we are dealing with portal hypertension. So, as you can see, regarding all these signs, we have two factors, which if you see one of them, this is for sure definitive portal hypertension. Number one, hepatofugal flow on color mode. Number two, velocity less than 10 centimeter per second. If you find any of these criteria, any one of this, not both, any one of this, hepatofugal or less than 10 centimeter per second, of course, you can write it as a definitive portal hypertension. Okay, the rest of signs are suggestive of increased portal vein diameter more than 16 millimeter is suggestive of portal hypertension. Bidirectional may be carry possibility of portal hypertension with the other possibility, and I will tell you how to differ from. Loss of respiratory physicity or increasing velocity less than 15 centimeter per second, suggestive of portal hypertension. Okay, but less than 10 centimeter per second, this is for sure portal hypertension. And please remember, loss of respiratory physicity, patient in this case, you should see that his chest is rising above and below. I mean, patient may have, normal patient, normal liver, may show loss of respiratory physicity if the patient have a problem with his chest. If he has asthma or chronic obstructive pulmonary disease, if he cannot take his breath normally, if he have a very shallow breath, you will not see his chest will not go up and down. There is no evident inspiration or expiration. So the effect on the portal vein, you see here, we have loss of respiratory physicity, not due to problem in the liver itself or portal vein itself, but it's due to problem in his chest. Okay. Also, velocity less than 15 centimeter per second. You should always measure it in a normal direction. You should always measure it. Patient in left lateral decubitus. Adjust your angle below 60. The vector is parallel to the blood flow. You should always put the portal vein at the corner of the color box. Remember the corners of color box in order to get the most accurate measurement of the portal vein. Okay, because many few will if they analysis the portal vein when it enter the liver and you activate your color box, putting the portal vein in the center of the box, you will see that the velocity will be 12 and 13. And you may suggest, so this is portal hypertension? No, this is the wrong measurement by your hand. Please do not ever record any velocity in portal vein unless you have complete color filling, unless you put the vessel in the corner of the box and adjust your scale and angle and vector correctly in order to get the most accurate assessment. Otherwise, you will always underestimate the velocity and you will get low velocity and you may misinterpret this as a portal hypertension. Okay? Okay. So let's start. In this case, yes, liver is cirrhotic, it's inhomogeneous, and the portal vein is dilated. I will not measure it inside the liver, I will not measure it in the confluence, but just distal to the confluence outside the liver, and I measure it from inner to inner. This is a 17 millimeter. With coarse liver, yes, it's highly suggestive of portal hypertension. Okay.